So, good morning, good afternoon, and good evening, everyone. Welcome to our virtual symposium on motion analysis techniques and musculoskeletal modeling of the spine to better understand spinal disorders and evaluate treatment effects. Let me just quickly introduce the organizing committee. For the ones who do not know us yet, or some of us yet, we have from Belgium, Leonard Skijs. He's the director of the Institute for Orthopedic Research and Training at KU Leuven. Then from the US, Dennis Anderson. He's an assistant professor of orthopedic surgery at Harvard Medical School. Also from the US, Babak Bazargari. He's an associate professor of biomedical engineering at the University of Kentucky. And from Switzerland, myself, Stefan Schmid. I'm a senior lecturer of movement biomechanics at the Bern University of Applied Sciences. The idea for organizing this symposium originated from one of our first meetings as guest associate editors for the same titled special issue in the journal Frontiers of Bioengineering Biotechnology, for which we, by the way, still accept manuscript submissions until the 5th of June. And I think most of you also know it because of that special issue. Yeah. So the symposium is structured in 3 sessions. The first session concerns the development and evaluation of motion analysis techniques for the spine. The session is chaired by Babak Bazargari. The second session addresses the evaluation of the effects of spinal disorders on motion and loading, and is chaired by Leonard Skijs. And in the third session, which is chaired by Dennis Anderson, we will look at clinical applications and interventions. Each session will contain presentations of 8 minutes. And for the presenters, please be on time. We just decided that we will mute the presenter after 9 minutes, or if you surpass 9 minutes of presentation, so that we can stay on track with the program. And in between the presentations, we will have about 2 minutes for answering 1 to 2 questions and to switch between the presenters. At the end of each session, there will be a discussion of 50 minutes for session 1 and 2 and 25 minutes for session 3. You can ask your questions anytime using the Q&A function or a raise hand function, which, however, only during the discussion. At the end of each session, you see here the raise hand and the Q&A functions highlighted with the red square. As previously announced, and as you can also read on the website, the symposium includes Best Paper Awards, which are sponsored by the open access publisher Frontiers, the motion capture company Viken, the medical technology company Medtronic, and NCSRR, the National Center for Simulation and Rehabilitation Research in the US. On behalf of the organizing committee, I would hereby like to thank our sponsors again for supporting this symposium with contributions towards the publication fees for manuscripts that are submitted to our special issue. So the papers will be evaluated each by 2 members of the evaluation committee, which consists of John Rasmussen from Aalborg University in Denmark, Fabio Galbuzera from the IRCCS in Italy, Jaap van Dien from the Vrije University Amsterdam in the Netherlands, Brad Hendershot from the DoD Extremity Trauma and Amputation Center of Excellence in the US, and ourselves, the members of the organizing committee. The evaluation criteria include scientific and clinical significance, scientific rigor, methodology, significance of the results, and finally, quality of presentation. And that also includes the abstract. So as already announced to the presenters beforehand, we will record the symposium. And the recordings are planned to be made available on the symposium website. If any one of the presenters that did not agree yet for the recording would prefer not to be recorded, you can notify us anytime by email and we will delete your recording. For simplicity, we record the whole symposium, and if you wouldn't want to be recorded in that sense or made available on the website, we'll just delete then your part. And before we go to the first session, just for all attendees and presenters, before you leave the symposium, or when you leave, actually, there should be an evaluation form popping up with 4 or 5 multiple choice questions. So you just have to click an answer for each question, and we would really appreciate if you could quickly fill out this evaluation form before you leave. Okay, with that said, I don't want to make it any longer, and I'll pass on the torch to my colleague Babak for the first session on the development and evaluation of motion analysis techniques for the spine. Please, Babak.
Thank you, Stefan. Welcome to our first session of symposium. We will have 3 presentations in this first session. As was described, each presentation is going to take about 8 minutes. If you have any question, you can just submit your questions throughout the presentation using the question and answer box. And then we will have time for answering one question at the end, and then we'll have a discussion panel toward the end to have a 15 minutes of discussion on all 3 papers. Our first presentation today will be from United Kingdom and will be presented by Dr. Breen. And the title of presentation is a reference database of standardized continuous lumbar intervertebral motion analysis for conducting patient-specific comparison. Dr. Breen has already sent us the recordings of the presentation, and we'll have that to be played now.
Over the past 10 years or so, we've been studying the potential of continuous, multi-level, in vivo intervertebral motion to reveal kinematic biomarkers for chronic nonspecific back pain. Most of these studies have been of the lumbar spine during sagittal plane standing flexion. Our approach has been to use 2D fluoroscopy during standardized and controlled outward and return bending to measure continuous multi-level motion. This has been driven by the premise that static, quasi-static, and end-of-range measurements are inadequate for detecting kinematic biomarkers, partly due to their inability to reveal true maxima, because these maxima are sometimes reached at different stages of the bend at different levels, especially if global motion is not standardized for range, velocity, and consistency. We've developed a reference database of kinematic values for standing, flexion, and return motion, based on a healthy control population of 127 males and females aged 18 to 70. Having achieved acceptable repeatability and accuracy for the technique, we have compiled normative values for IV-ROM, translation, dynamic disc height, and initial attainment rate. However, we found no significant differences between various patient cohorts and the control population for these variables. However, things changed when we compared cohorts in terms of proportional intervertebral motion, using the kind of data that you see here. The variables of interest were segmental motion sharing inequality, MSI, and variability, MSV, across the motion cycle, where motion sharing inequality is the average difference between the level that accepts the most and the least motion, and motion sharing variability is its standard deviation. We previously used the sagittal weight-bearing flexion and return protocol to compare 20 controls with 20 back pain patients, and found that MSV correlated strongly with age and disc degeneration, but in patients only, a finding that was later replicated, but so far defies explanation. However, the measurable differences between these 2 phenotypes can be found in this paper, which was published in 2018. A follow-up study of a subpopulation in published in 2020, also found that L3-4 contributed significantly more rotation in patients. L4-5 rotation was significantly more variable in patients, and L5-S1 contributed significantly less rotation in patients. While our previous studies have measured intervertebral flexion and return motion as a cycle of motion, as shown here, there's interest in the return phase of the motion by the spine biomechanics community due to its relevance for lifting tasks. Subsequently, we divided the sequences into outward and return phases as shown here. To explore possible further biomarkers, we used sequences from 8 patients and 8 controls, matched as closely as possible for age, gender, and BMI, and compared them for MSI and MSV, plus their average share of the motion, average motion share, at individuals' levels and its variation. The results shown here suggest that, as in some of our previous flexion and return studies, motion sharing inequality was greater in patients. L5-S1's average share of the motion was also less in the return phase, which is clearly shown here. L2-3 accepted a greater share in patients and L5-S1 less. The inequality of motion sharing is higher in the patients. To conceptualize this, if you could capture the maximum IV ROM for each segment, wherever it happens, in a single image, it might look something like this for controls and chronic non-specific low back pain patients. The most notable difference between patients and controls in this slide is the limited motion at L5-S1 in patients and its apparent compensation at L2-3 and perhaps beyond. It wouldn't look exactly like this because each motion segment reaches its maximum ROM in a different image frame in the motion. This kind of information may be useful, though, as reference data for biomechanical modeling, if the fact that motion sharing is constantly changing is taken into consideration. In a participant-by-participant comparison, there was little difference in terms of motion sharing inequality, but L5-S1's average share of the motion was still less in the patients in the return phase. In the levels higher up, L4-5 accepted slightly more share and variation in the patients, while L3-4 showed similar motion sharing, but more variability in the patients than in the controls. Finally, L2-3 also accepted a greater share, but with less variability in the patients, suggesting perhaps alterations in the control by the deep multifidus and erector spinae muscle groups in people with back pain. None of these comparisons, however, were statistically significant in this small sample. Our abstract in your abstract book shows an individual patient example, which is reproduced in this slide. While subjectively this shows some of the features I've just described in our 8-patient cohort, notably the high MSI, not all the features are present. This slide shows all 8 patients and 8 controls return phase motion sharing patterns. Arguably, there appears to be greater heterogeneity in the patients. The finding of more patients exhibiting a lower share of the motion at L5-S1 compared to the controls and to the control database stands out as a feature. The database could therefore perhaps also be used for normative values for comparison in individual patient assessments. These could include, for example, in vivo studies of surgical implant behavior. The data are also proposed for modeling in combination with other variables such as loading, motor control, muscle metabolism, spine geometry, degenerative change, and disc properties. Such studies may contribute to deconstruction of the biomarkers found and explanation for nociceptive pain generation. This may, in turn, guide the application of individual conservative management approaches such as movement training. So to conclude, the reference database exhibits consistent motion sharing patterns during both outward and return continuous motion in a pain-free population. This is despite some heterogeneity in the participants' characteristics. Differences in the return phase between patient and control subgroups seem to complement these previously found in studies that combined outward and return motion. However, the return phase findings have yet to be replicated in other symptomatic populations. So thank you very much for listening. I'm happy to take any questions. If you want to contact me, though, here's my email address.
Thank you, Dr. Breen. Dr. Breen is now with us, and we have time for 1 or 2 questions. Just to remind the attendees about how you can ask questions. You can either post your question in question and answer box, or you can raise your hand and we can unmute you and you can ask your question. So I don't see yet any question coming in. So I'm going to ask first question myself, so giving time to attendees to just, if they are posting their questions, to sending in. So this was a very interesting study, Dr. Breen, and because as a person that have been doing a lot of modeling myself and knowing the value of having the intersegmental kinematics of lumbar vertebrae, how it's just influenced the prediction of muscle force in studies of lower back biomechanics. The question that I have is, I was looking at the control data in the abstract and the contribution of L4, L5 segment. And it was interesting to me that contribution was quite different in outward movement versus return movement. And I was just thinking, if a given segment is being deformed a given amount, it will need to be just undeformed on the way coming back. Do you have any explanation of that behavior?
I think I have a feeling that the reason for that is the different participation of the back muscles going out and going back. Because going out, there's greater participation of the guiding multifidus, and coming back, there's greater participation, I believe, of the big erector spinae group. So it's a different motion pattern because it's a different combination of muscle effects. And sort of going on from that, I think perhaps in people with non-specific low back pain, that's disrupted. That coordination is different. That's only my impression. I could be completely wrong, but that's my explanation for this difference between the outward and return paths at L4-5, because it's right in the middle of that.
Yep, that's a very interesting behavior. And I see there are a number of questions coming in. I'm going to ask one of these questions and keep the second one for the discussion, or panel discussion. I wonder if the patient can be classified by segment motion dysfunction with the normative values.
That's a very good question. You could classify them in terms of whether they fit this model of less L5 participation in the return phase and a different type of L2-3 participation. But I don't know where you would, how much further you could take that without having another biomarker to bounce off it. Like, for example, muscle metabolic overload, or maybe even just morphology, the degree of lordosis. So what we're constantly looking for is a group of biomarkers that we can deconstruct and construct an explanation. But we haven't got many yet, as the answer.
Okay. All right. Thank you. So there's another question that we're going to keep that for the panel discussion. Thank you again. We're moving forward with our second presentation. So our second presentation is going to be from Belgium and will be presented by Thomas Overber. And the title of his presentation is going to be Subject-Specific Spinopelvic Models Reliably Measure Spinal Kinematic During Forward Bending in Adult Spinal Deformity. Thomas, go ahead.
Yes, thank you for the opportunity to present the work my colleagues and I have been doing about kinematic simulation in a spinal deformity population. So, in previously published work, we created a workflow that allows to analyze intervertebral joint kinematics in a spinal deformity population during different motion tasks. Very briefly, in the first step, making use of a dedicated skin marker protocol, we collect motion capture data of, for example, a forward trunk flexion. Also, while wearing the markers, a full body biplanar radiographic image is taken using the EOS system, and this in an upright load-bearing position. Lastly, as part of their clinical routine treatment in our university hospital, they receive a full spine CT. In the next step, we process the motion capture data using Vicon, and the medical image data is used to create a subject-specific model, on which I will elaborate later. The model and the motion capture data are then combined in the inverse kinematics algorithm of OpenSim to obtain simulations on the intervertebral joint motion. This workflow was validated for accuracy, but its reliability for routinely simulating kinematics wasn't quantified yet. Both are important towards future clinical interpretations. In this work, we will focus on two previously uninvestigated workflow components. The first one is related to intra-subject variability. To quantify this intra-subject variability, we defined a test-retest study in which 4 ASD patients and 1 control subject performed a maximal forward trunk flexion, and this twice over a 2-week time interval. The entire processing workflow was followed for each session, after which the simulated kinematics were converted to commonly used spinopelvic parameters, as illustrated by the figure on the right. To quantify the repeatability, intra-class correlation coefficients were then determined. To illustrate the results, a lateral and a frontal view of the simulations of one of the subjects is shown at the bottom. And at the top, one of the spinopelvic parameters, namely the T1 spinopelvic inclination angle, is shown for both sessions. Overall, for this test, we obtained good intra-class correlation coefficients, shown in this second column, except for the thoracic kyphosis parameter, which had a very low repeatability. Now, going back to the overview of our workflow, the second component which we will investigate for reliability is this modeling component. If you go into a bit more detail about the modeling component, first we use the subject's CT segmented bone geometries as the building blocks for our model. Then, based on the biplanar radiographs, the spinal alignment of the subject is reconstructed as well as the associated markers. Lastly, the intervertebral joint is personalized based on the mesh of the vertebral discs constituting each joint. Now, unfortunately, each of these steps partly relies on manual input of an operator, causing an additional operator-dependent variability on the model and thereby also on the simulation output. To quantify this variability, 3 trained operators were asked to create their own subject-specific model of the same 3 ASD subjects. And thereafter, each of the models was used to perform an inverse kinematic simulation. A video of the superimposed simulations of one subject is shown at the bottom. And here the simulation outputs were again converted to commonly used spinopelvic parameters, of which the T1 spinopelvic inclination angle is again shown as an example. The ICC values were all in excellent agreement, as was expected from the graph in the previous slide, where the curves were already very close together. And lastly, to have a better idea about the inter-operator variability, but on the individual vertebral levels, we used a Monte Carlo probabilistic simulation approach. This method created 1,000 statistically probable model variations based on the experimentally determined variability of the operator-dependent model parameters. We identified 3 operator-dependent parameter components in our model, namely the definition of the markers, the spinal alignment, and the joints. As an example, the histograms of the operator variability of marker definition are shown on the right, together with an estimate of the probability density functions, which are then used as an input for the Monte Carlo simulation. So each of the 1,000 created model variations was used to run an inverse kinematic simulation. This allowed us to define a 90% confidence interval on our intervertebral joint kinematics. We summarized the variability for the 3 subjects in box plots based on the time instance of maximal variance, meaning at the worst time during the motion. For our 3 subjects, we obtained 90% confidence intervals that were on average lower than 2 degrees. So we analyzed the impact of 2 previously unknown sources of variability in our workflow on the kinematic simulation outputs to determine its overall reliability. First, with the exception of 1 parameter, we noted good intra-class correlation coefficients for the intra-subject variability. Thereafter, the 3 operators presented with a very high inter-operator agreement. And finally, our Monte Carlo simulation provided quantitative measures about the to be expected operator variability at intervertebral joints. We concluded that our workflow is able to reliably measure intervertebral joint kinematics. However, as the largest variability originated from intra-subject differences, improvements in the standardization of the performed motion could increase the reliability even further. Thank you.
Thank you, Thomas. We have received a number of questions, but again, I'm going to remind our attendees that there are 2 ways that you can ask a question, either by putting or writing your questions in question and answer box or by raising your hand. And to help us better manage this, if you are writing your question in question and answer box, at the beginning of your question, could you just verify which presentation you are asking that question? So I see like these 2 questions for Thomas' presentation. I'm going to ask the first one and see if we have time for the second one. Do you think a set of standardized models could be made for different curve types, locations that could be simply personalized for cup angles?
Yes, I think in the future that may be a good idea to reduce the time cost of creating these subject-specific models, which I didn't mention right now, but it's pretty high. But that's, yeah, using a more statistically based model, yeah, it could save a lot of time, and I think should be feasible, yes.
Okay, we have time for another question. The second question is, how was the material properties modeled? Was BMD, bone mineral density, and soft tissue properties varied?
Those 2 weren't varied because our OpenSim model is a rigid body model, so it doesn't incorporate soft tissue when we look at kinematics, of course. If we would go to kinetics or muscle activation, then it would be important to include them in our sensitivity studies. But here it wasn't part of the study, no.
Okay, there is one third question that we are going to keep this for discussion panel. Thank you, Thomas.
Thank you.
With this, we are moving to the last presentation of our session, which is going to be again from Belgium. This presentation will be presented by Peter Severin, and the title of presentation is Spinal Palpation Error and its Impact on Skin Marker-Based Spinal and Alignment Measurement in Adult Spinal Deformity. Peter, go ahead.
So hello everyone, and thank you for the introduction. So recently there has been a shift in spinal deformity research from mainly static radiographic alignment measurement towards dynamic spinal alignment measurement using skin marker-based motion capture for both adolescent idiopathic scoliosis as well as for ASD. And this shift allowed to measure spinal alignment during motion. The validity of such skin marker-based methods is highly dependent on correct marker placement, and palpation error has been investigated in both AIS as well as in healthy spines, but mostly in 2D. And the results of these studies vary largely. This is mostly due to different methodologies to calculate as well as to visualize palpation error. Interestingly, palpation error had a negative impact on spinal alignment measurement in AIS. Marker misplacement resulted in an underestimation of coronal scoliotic curves. Since palpation error was never investigated in ASD, the aims of this research were to quantify the 3D spinal palpation error in deformed adult spines and compare it to healthy non-deformed spines, to explore the underlying reasons for palpation error by looking to associations with radiographic alignment as well as body morphology, and also to assess the impact of this incorrect marker placement on marker-based spinal alignment measurement. In this study, we included 20 adults, as well as 20 adults with ASD, as well as 10 adults with normal spinal alignment. And all these subjects were instrumented with a spinal marker protocol. They received biplanar imaging to quantify the palpation error, but also to measure their radiographic spinal alignment. And after biplanar imaging, a static trial was captured in our motion lab to assess the impact of palpation error on marker-based spinal alignment. Palpation error was quantified for the thoracolumbar and the lumbar levels instrumented with a marker, and these were T11, T12, L2, L3, and L4. And for each level, 3 points were identified on the sagittal and the coronal images using a custom software, which allowed us to obtain the 3D coordinates. These points were the spinous process, the optimal marker position, and the actual marker position. These 3D coordinates could then be used to calculate 3D palpation error, as well as the 2D palpation error in the medial lateral and the inferior-superior error. If we zoom in on the sagittal and the coronal images of one level, you see that the optimal marker position is obtained through a circle fitting from the processus spinosus towards the closest point on the skin surface. This distance was also used to obtain soft tissue thickness, which we need for the associations with body morphology. We also assessed if a marker was placed at the correct spinal level, and therefore we assessed whether the boundaries of a marker base fell within the boundaries of the corresponding processus spinosus. So on the image on the left, you see that all these markers are identified correctly, but on the right, you see that L2, L3, and L4 markers have been placed one level too high. Marker-based spinal alignment was measured with a previously validated method using a polynomial and allowing for marker position correction. As such, we used 3 different levels of correction. So in red, we have the actual marker positions, so no correction. In blue, we have the optimal marker positions, so correction for palpation error. And then in green, you see a correction towards the vertebral body, so a correction for the anatomy of the subject. A polynomial was then fit through the different corrected marker positions in the motion trial to assess spinal alignment. By assessing the concurrent validity between the marker-based and the radiographic spinal alignment, the impact of marker misplacement on spinal alignment measurement was investigated. Marker-based lumbar lordosis and scoliosis were compared to their radiographic equivalent using correlation analysis and root mean square error, and this was done for the 3 different correction levels, so for no correction, palpation error correction, and vertebral body correction. Let's go to our results. The 3D and the inferior-superior palpation error were actually not different between both groups, but if you look at the medial lateral palpation error, we see a larger mean and maximal palpation error in the ASD group, and especially for the T12 and L3 levels. Level identification was quite similar between groups. However, in the ASD group, we actually saw a larger proportion of incorrect level identification in the lumbar spine, in contrast with a more equal distribution in the normal alignment group. Correlation analysis showed that larger scoliosis was associated with higher medial lateral palpation error in the ASD group. And in healthy spines, we saw significant relations to body morphology, namely an increased BMI and an increased soft tissue thickness were associated with larger palpation error. If we look at our marker-based spinal alignment, we see that all three marker-based methods, so all levels of correction, could distinguish ASD subjects from control subjects. We see significant correlations in the ASD group between the non-corrected and the palpation error-corrected spinal alignment measurement and the radiographic equivalent of lumbar lordosis. And the root mean square error of the palpation error-corrected method was actually smaller compared to no correction. However, the vertebral body correction seems to provide the most accurate results, which is also seen in the bar graph on the left. For scoliosis, the palpation error-corrected method outperformed the method without correction on both the correlation as well as the root mean square error, but also here for scoliosis, correction towards the vertebral body provides the most accurate marker-based spinal alignment results. This brings us to our discussion. So medial lateral palpation error seems to be larger in deformed compared to non-deformed spines. And this is mostly explained by the scoliosis deformity, which has a rotational component in which the processus spinosus is directed towards the concave side of the curve, and therefore their location might be less predictable. In control subjects, body morphology seems to be the most determining factor for palpation error. Spinal level identification was surprisingly similar across groups. However, it's worth mentioning that in the ASD group, especially the lumbar levels were incorrectly identified. And this can be due to the combination of larger deformities in ASD in the lumbar spine, as well as more soft tissue thickness in this lumbar region. At last, we observed that marker misplacement indeed had an impact on spinal alignment measurement, and especially in the coronal plane. And this was observed since palpation error correction resulted in improved correlations for scoliosis with radiographic scoliosis, a decreased root mean square error, and also a reduced underestimation of the curve, as you can see here on this picture. So blue is the palpation error corrected method, and red is the non-corrected method. So therefore, palpation errors should be considered when interpreting spinal kinematic results. And this also stressed the need for marker position correction methods. However, it's also worth mentioning that when correcting the marker positions towards the vertebral body positions, this resulted in the most accurate results. So when correction of markers is possible, then the vertebral body is actually the landmark that should be aimed for and maybe not the optimal skin position. Thank you for your time and for your attention.
Thank you, Peter. So again, to remind our attendees, there are two ways that you can ask your question, either by writing your question in the question and answer panel at the bottom of the Zoom screen, and either by raising your hand. So we have one question in the question and answer. Thank you for the presentation. This must be very important when creating a patient-specific spine alignment from a generic spine atlas. In case where there is a deformity of the vertebra themselves, how would you account for the geometric difference between the atlas and patient-specific vertebrae?
Okay, thank you. It's an interesting question, but actually what I do in my method is I stick to the markers and I not go into modeling of the spine as the presentation of Thomas just was on. So what I actually do is on a radiographic image, I correct to the position of the vertebra, but I do not do any corrections on the geometry of the spinal alignment or of the spine. So I only correct for the alignment, but not for the geometry of the vertebrae.
Okay, thank you, Thomas. So maybe a question from myself. I noted that you have looked at the influence of severity of the deformity on the error. Have you looked at other parameters, for example, age or gender, or if and that's one question. And the other thing would be, what would be the applicability of this result if you want to just guess about palpation error in other individuals with spinal disorder, maybe those with chronic back pain, but not spinal deformity?
So regarding other parameters such as age or gender, we didn't look into that, but I assume that age will have an impact on the alignment of the subject for sure. And regarding gender, there might be differences, especially in body morphology, I guess. So I guess that the differences in gender would be mainly on soft tissue thickness and maybe also alignment. But we didn't look into that yet. But I would expect some differences there. And then your second question, can you please repeat it?
Yeah, I mean, this was like, mainly on individual with a spinal deformity, right? Like if you want to think about other individuals with a spinal disorder, say people with chronic non-specific low back pain, do you expect to see like some differences in palpation error as compared to control?
I think that those differences would be less, since what we saw now was that mainly that scoliosis deformity is the main contributor of the errors we measured. So as long as the alignment of the low back pain patient will be the same as for the control subject, I wouldn't expect the same differences as we saw now in our results.
Okay, thank you. So we have two more questions. I think that we are just going to move to the discussion panel. And I'm going to ask this question, like, during the discussion panel. So I'm going to ask our three presenters to unmute themselves. And I'm going to start by asking I think the first question was from Dr. Breen. If I'm correct here, did you look at the effect of different pelvic morphology, such as pelvic depth, pelvic incidence on segmental motion?
No, we did not. The reason for that was to contain the radiation dose, because to look at pelvic incidence and sagittal balance, you need to appreciate both the pelvis, the hip joints, and the rest of the lumbar spine, which would mean an additional set of imaging. So we haven't got as far as doing that yet, although some colleagues in the United States have, but they're not research colleagues, so it's been done for surgical practice. So sorry, the answer is no.
Okay, thank you. We have two questions from Yap and Dean. If you would like, Yap, we can unmute you and you can ask both questions. If someone can unmute, let me see if I can do that myself.
I think I'm unmuted now.
Okay, go ahead. Yeah, please go ahead.
Thank you, Babak. Basically, it's sort of a similar question to both Thomas and Peter. The promise, of course, of your methods is that you can apply it to dynamic movements, whereas the testing of reliability, but also the testing of the palpation error effects and the corrections for that are both static. So I was wondering, to what extent do you think your results can be extrapolated to dynamic measures? And maybe as a follow-up, do you see any possibility for collaborating with Ellen on this?
So maybe I can start. So indeed, what we want to do is measure spinal alignment during motion. For the study I now just presented on palpation error, I would expect that those markers will move, or there will be some skin motion artifact when moving. So those markers will not track the vertebrae as we hope they will. Mm-hmm. What we plan to do is validate in the future also banded X-rays. So when we reposition the subject, then we could compare the palpation error we measured now on that static alignment to the palpation error we measure on that second banded radiograph. So then we have two positions and we have somehow motion, or let's say semi-static motion. So that's a way of validating it in the future. and then I think I give the word to Thomas to elaborate on that.
Well, yes, I agree with you, of course, Peter. More specific to my methods, the only way to really validate dynamic motion with regards to the simulation output is, of course, to use continuous fluoroscopy, which we don't have access to at the moment. But if any one of the participants would like to collaborate with us on that, we would be very happy to do that.
Okay, thank you. We have a question from Ayman Asi. If moderator can unmute Dr. Asi. Ayman, if you are on mute, go ahead and speak. Okay, so looks like I'm going to ask like Ayman's questions. This is to Thomas. Very nice presentation. Does the use of workflow? Oh, go ahead, Ayman.
Is it working? Yes, sorry. Yes, yes. I was asking Thomas actually if is it possible to have patients enrolled in this workflow, but without doing the CT scan for all of them, or is it a necessity to do the CT scan for each patient enrolled?
Yeah, it's a very good question. So in our workflow, we make use of CT, from which we can extract the exact vertebral geometry. This has two main functions. First, the highly detailed shape greatly facilitates the radiograph-based alignment reconstruction. And there we try to match the projection of the vertebral geometry onto the radiograph. And this allows us to, when we use the CT segmented bones, it allows us to reconstruct with a much higher accuracy because we can match landmarks very well onto the radiograph. And secondly, our intervertebral joint definition is using the mesh of the segmented vertebrae. So yeah, that's an advantage too. So in my opinion, in a degenerative population where there's typically vertebral deformation, investing a high amount of time to segment the CT is justified, as it will increase the accuracy of the modeling. Of course, in next steps, we might try to decrease the amount of detail and check how sensitive our kinematic output is to that, and in that sense try to match the additional time cost with the additional accuracy.
Okay, thank you.
Thank you, Peter. The next question is from Felipe. I'm going to unmute you, Felipe. Go ahead and.
Thank you. Yes, this question is for Dr. Bean. I was wondering if the analysis of the percentile curve, I mean, it was done like globally, but maybe I misunderstood that part. But my question is if this analysis of the percentile curve can be presented by segment, and then if it's presented by segment, if we have a percentile curve per segment, then it could be a little more easy to classify these functions per segment also. And do you think this is possible with your data, or is not possible?
Is that a question for me?
Yes, yes, Dr.
Right,
Brand,
thank you.
yeah.
Yes, it can certainly be done by segment. You could do it from the actual ROM, or what we've chosen to do now is to do it as a proportion of the overall L2 to S1 motion. But for any given segment, you can present that as if this is what you meant, the motion pattern as a proportion of the motion pattern of L2 to S1 individually.
Is it possible to have access to the database? Is it possible to do collaboration to try to understand maybe
Yes,
how it can be done this, because for me as a clinical point of view, one of the things that are more important is to recognize the segment dysfunction.
sure. We're very happy to share the database. You're very welcome to have it. So you have my email address. If you want to contact me, we can discuss how to do that if you want to.
Thank you. Thank you very much.
Okay, thank you. We have one more question from Diane. I'm going to unmute you. Go ahead.
Hi. So my question is for Peter. Thank you for your presentation. So I'm not sure whether I missed it due to unstable connection or not, if you said it before, but were the market-based alignment changes or the palpation errors exacerbated with increased BMI? So I was wondering if you were able to look at this or at special populations such as the high-risk patients with obesity or pregnancy.
So what we did was, on our subject with ASD and on our control subjects, we measured BMI and we correlated it to the palpation error we measured. So that was basically what we did, and what we saw was that for the control subjects, BMI was a predictor of palpation error. We didn't see that in the ASD subjects. There were moderate correlations, but they were not significant. But what I expect is that this might be also the case for those subjects, but that was just hidden by the spinal deformity, which was correlating a lot in these patients. But we didn't look at other groups than those spinal deformity patients and control subjects.
Thank you.
Thanks. I see a question in the chat box for Dr. Breen. You mentioned the standardization of your motion as an important asset of your data set. Can you share some practical tips in standardizing a forward flexion motion and the trade-off with regards allowing the pathology to play its role?
Well, really, standardization is in order to minimize extraneous variation, which has got nothing to do with the pathology or the functional derangement. So the attempt is to exclude anything which is not relevant to the functional derangement itself. So in the setup that we have, we're first of all concerned that the person doesn't go out of the image field. We're also concerned that the person's speed of motion is standard, so that the muscle responses are not variable, in an uncontrolled and unexpected way. So it's the end of the motion and the reversing of the motion could also disrupt whatever muscle patterns are happening there. So if you're looking at non-specific low back pain, that's important. If you're looking at problems with restraint, it's probably better not to use that weight-bearing pattern at all, but to use passive recumbent pattern where only the passive holding elements are active. In other words, the resting muscle mass, the ligaments, and the disc. So if you were looking for spine stability, passive system stability, I would recommend that you don't use the upright pattern and you use a passive recumbent pattern, which we've also got.
Okay, thank you. So now I have myself a last question from all the presenters. I'm doing a spine biomechanics as well, whole body level kinematics. And in as an element of evaluation biomechanics, we typically ask patient to just do this forward bending and backward return task, similar to Dr. Breen, movement. But when I look at the literature, there are different ways of doing that flexion extension. Some people do it in a standing posture, some doing it in the sitting posture. There are different ways of measurement, people do motion capture, more people are using inertial measurement units. There are variation in methods and movement, and that make it very difficult to just draw a conclusion from different studies. I want to hear your opinion about an effort to come up with some standardized way of like characterizing like, movement, like some standardized movement, some standardized characterization of like, like methodology in terms of like, where to put markers, like, what is going to characterize like pelvic movement or thorax movement. I just want to have like hear your opinion about like that like effort, if someone to go ahead and just like, push for those efforts.
Well, but maybe I'll start with a part of your question. In our group, we try to start from motions that are typically performed in the daily life of patients with spinal deformity. In our population of around 60 years old, we heard that there were some complaints with putting on shoes, putting on socks, tying the shoes, and therefore we perform our spine flexion motion in a seated position and allow them to reach as far as possible. So that was the reasoning that we followed.
Okay, but like my thought is like, should we as a scientific community like work together to come up with like some standardized like, way of like, like this is going to be a standardized movement. So then like, we have multiple groups using the same methodology, then it would be like, a much larger sample to look at like, dysfunctions, how like, spinal disorder impact like, kinematics or kinetics.
Yeah, I think that would be really nice indeed to allow comparison of the results. Although that we have noticed that if you try to standardize the motion too much, then you also affect the way that person moves. For example, some subjects might not go that far in a flexion, but yet try to reach a preset target and thereby moving in a different way than he or she would normally do. So I agree with trying to standardize it, but we should also allow freedom for inter-subject differences.
Can I just say, I completely agree with that. You have to start somewhere. We started with an international forum on how it should be done, and then went from there. We have also seen studies where it's been done in the seated position, and we've studied what that difference makes, and it's quite a systematic difference. The last thing to say really, I think, is that any kind of standardization produces an artificial movement pattern, but at least it's a standard movement pattern which you can study the variations from between and within individuals.
I think a last remark on that is if you look at the methodology, how you would then measure that movement, because we now saw 3 presentations with 3 completely different ways of measuring alignment of the spine or movement of the spine, and which is a good thing, of course, because we need more research, because we also see that all those methods have still their limitations. And until we find that method with, let's say, the least limitations, being it costs or measurement errors or all those aspects, if we could come to that method, then standardization is, of course, the way to go. But as long as all those methods have their downfalls, then I think we need all this research, and we should discuss on it, of course, to go to those or that standardization for sure, because it would make things easier if we have a standard protocol with a standard measurement protocol, of course.
Yep. Thank you so much. I see there is one more question, but we don't have time. Unfortunately, Youssef, we cannot answer your question. And in the interest of time, we're gonna bring to an end this session. Thank you, everyone, the presenters and the attendees. With that, I handed this over to, I think it's gonna be Leonard, who will be chairing the second session.